The first thing is it safe? Am I going to wake up? The short answer to that is yes. I went and pulled some statistics for you, and you know, it's kind of hard to figure out sometimes when you have problems in surgery, whether it's surgery or whether it's anesthesia. And so, you know, the best we can come up with is probably somewhere around 1 in 200,000 anesthetics, there's actually a problem with anesthesia. And, you know, the percentage on that is like 0.3 zeros and a 5, okay? Really, really small. In comparison, if you get in a car accident, okay, you have a 0.66% chance of dying. That's 1,320 times greater chance of dying if you get in a car accident than if you have an anesthetic. So if you're worried about going to sleep for a surgery or a surgical procedure, you probably shouldn't be getting in a car. Okay? Let's talk about the flu. I don't mean swine flu or H1N1, regular seasonal flu. If you get the flu, you have a 0.06% chance of dying. That is 120 times greater than dying from anesthesia. So if you're worried about having an anesthetic, you should probably never go out in public because you might get the flu. Okay, that's how safe anesthesia is today. And, you know, the Anesthesia Safety Foundation, there is a foundation specifically for safety in anesthesia, has been one of the leaders in the medical profession in how we have tried through the years to make anesthesia more and more safe for people. Our anesthesia machines, as an example, those are the machines that help you breathe and give you gases and oxygen during surgery. They're almost idiot-proof. Everything is color coordinated. Anything that connects together is pin indexed, so you can't connect the wrong things to each other. There's a lockout system so that you cannot even give a mixture of gases that's too low in oxygen. So we can't, you know, just accidentally make you hypoxic. You know, it's just, everything has been worked so well. And then the things that we monitor, you know, you think that we come in there and just give you drugs. Doesn't quite work that way. You know, while we're in there, while you're asleep, we're constantly monitoring your oxygen levels. We're constantly monitoring your carbon dioxide levels. We've got alarms and bells and whistles that go off if the pressure in the system is too high, if you're not breathing well enough, if you're breathing too fast. You know, just, these are things that we're with you monitoring constantly during surgery. The Anesthesia Safety Foundation was really the first medical specialty that actually sat down, wrote out, came up with standards for safety. Okay, some of the others have followed suit, but not all medical professions have done that. But we were the leaders in that, and we were also leaders in using simulators in training our new anesthesiologists. So just like the airline pilots are using simulators, we're using simulators to train the new residents that come out. That's safety. Your second question is going to be, am I going to get sick afterwards? You know, am I going to get nauseated? I'm going to throw up. The answer to that one is maybe, but probably not. It used to be, when I first went into practice, which is like 25 years ago, so I'm the old one here in the crowd now, that 35% of patients got sick afterwards. If you had a high-risk surgery for nausea and vomiting, such as inner ear surgery, eye muscle surgery, laparoscopies, things like that, 70% of people got sick and threw up. So if you were walking through a recovery room somewhere, somebody was going to be throwing up. It's not that way anymore. You know, in my institution, we track all kinds of things. One of the things that we track is what makes patients stay longer than they should. It's an outpatient center, and we like our patients to go home in an hour. So if anybody stays longer than 90 minutes, we want to know why. Typically there's one a month, and we do about 2,000 patients a year, and about 200 patients a month. So, you know, that's really not very many. And the reason why we're so good at that is because of the drugs that we use to help combat nausea and vomiting, and because the drugs that we use for anesthesia now are better. And I have to, you know, give my hats off to the oncologists, because typically they're the ones that use the anti-nausea medicines first, and then we steal them. Okay? So, you know, if you're coming to surgery, you're getting really all of the same medications for nausea and vomiting that you're getting when you have chemotherapy. And so, that's a good thing. One drug in particular that I would like to point out to you that you might want to write down if you think you're going to head for surgery, and that's a drug called Emend. The reason why I'm pointing that out is because once you get to me, it's too late. I can't give it to you. It's a really good anti-nausea drug for prevention, and it's always better to prevent than to treat. So we wouldn't give it to somebody who was afraid of getting nauseated. We wouldn't give it to somebody who had just maybe just a little mild nausea. But there are some people who react to anesthesia. No matter what you do, they're going to get nauseated. And there are some surgeons that are really in tune to this, and there are some that are not. And so it's something that you have to ask your surgeon about if he doesn't come up with it. If he doesn't say to you, well, we're going to put you to sleep if you had any problems, you may not remember to say, oh yeah, every procedure I've had, it's been a problem. But, if you talk to your surgeon about it, he can order it for you because it's something that you have to take within, say, 2 or 3 hours before anesthesia. And by the time you see me, it's maybe 10 minutes before anesthesia, and it's too late. So let me just throw that out there. You guys can write it down. Your third question is going to be, am I going to have pain? The short answer to that is yes, some. But what you need to know is that your surgeon and your anesthesiologist are working together to make sure that you have as little as possible. They are a team, and they are committed to that. Okay, so you need to remember that. In the operating room, your anesthesiologist will give you pain medication through your IV before you ever wake up. So it's not like you're going to wake up cold turkey and have pain. Your surgeon, in many situations, will be infiltrating local anesthetics into the site of surgery so that that area is actually numbed up before surgery or before you wake up. Sometimes the surgeons will actually put a small catheter into the site that can stay there for 2 or 3 days and drip numbing medicine into the site of your wound. Okay, so we have lots of things that we can do. In the recovery room, your nurses will already have orders for pain medication before you even actually are aware that you're awake, so that as soon as you need something, the orders are already there. If you're in the hospital, you may have something called a PCA, or patient-controlled analgesia, where you can just push a button and you'll get pain relief. Okay, you don't even have to call your nurse. And yes, there are lockouts on that, so you can't overdose yourself. One other rather unique thing that I think is really cool, and that's, well, I like regional anesthesia. And not every center is going to have this, but let me just point it out to you, is that we can do nerve blocks for patients that are having breast surgery, whether it's a mastectomy, whether one side or the other, whether it's reconstruction. What that entails is pretend like this is your spine, your backbone, okay? We can put needles down on beside your spine, depending on how big of an area you're going to be operated on. And we can put numbing medicine, just like the dentist numbs up your mouth. If you're being operated on one side, we'll do it just on one side. If you're having a bilateral procedure, we'll do it on both sides. And what happens then is that you end up with a band of numbness, like this. Typically, where I work, that would be done before surgery. And so that during anesthesia, we have to really only give you a small amount of anesthesia. You feel a lot better when you wake up because you haven't had a lot of drugs, and you're pain-free, okay? If the right medication is put in there, that can last for up to 12 to 18 hours. So you can be asking your surgeons and asking your anesthesiologists about that. Not everybody knows how to do it, but certainly if you're at a teaching center, they ought to be able to find somebody who knows how to do that. And I do know that Loma Linda University is able to offer that. So let me just throw that one out there. One more thing. You may not all think about, but it's a question that I get like every other day. What about the Michael Jackson drug? Propofol. People come in and they go, I don't want the Michael Jackson drug. And so then I have to educate them and explain to them that, it's a really safe drug. It's called propofol. Plus he had a bunch of other drugs. And the problem is he had people giving him drugs that didn't know how to use the drugs, didn't know how to take care of somebody who had a problem with the drugs, shouldn't have been giving it in that setting, had no monitoring equipment, had no resuscitative equipment, and it's not the drug, okay? It's a good drug. It's a safe drug, okay? So that's Anesthesia 101.